Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're talking all about anemia and really getting into those different types of anemia. As always, though, let's kick it off with our practice question, and we will circle back to the correct answer at the end of the episode. We have a nurse reviewing the charts of 4 clients with anemia. Which assessment finding is most consistent with vitamin B12 or pernicious anemia? We have A, fatigue, pallor, brittle spoon-shaped nails, and a craving for ice. B, jaundice, dark tea-colored urine, and flank pain. C, numbness and tingling in the hands and feet with a smooth, beefy red tongue. And lastly, D, sudden hypotension and tachycardia after a large upper GI bleed. Okay, I'm going to go ahead and give you a spoiler alert here. All of these clients are showing classic signs of some type of anemia. Today, we're going to really look at those different types and figure out those key words and assessment findings that you have got to know. So think about what option might fit that vitamin B12 deficiency anemia, and we'll circle back at the end. Before we get into like the nitty-gritty of all the types though, honestly, we need to understand what anemia is, and to understand that, we need to know what our red blood cells are doing for us, because at its core, anemia is a problem with oxygen delivery. And that oxygen delivery comes from our red blood cells, right? That's their main job. I always describe them as the Uber driver that's going around our body. They're picking up oxygen and bringing it to every cell in our body, dropping that oxygen off. So with anemia, we got something going on with those Uber drivers. We don't have enough red blood cells. The Uber drivers are on strike and they're just like not doing their job. Or they don't have enough hemoglobin inside those red blood cells. The actual cars are dysfunctional. Maybe the cells are weirdly shaped or sized and they can't carry oxygen effectively. They can't pick up that passenger of that oxygen like they need to. And depending on how it is happening, the symptoms will show up differently. But I think important to just go ahead and say from the get-go, the end result is the same. Tissues are not getting the oxygen that they need, and the body has to compensate. So backing it up, let's talk red blood cells briefly. Where are they made? They're in the bone marrow. The bone marrow is a busy factory with a recipe to make red blood cells. We've got a few key ingredients that go into this recipe. Iron to build hemoglobin. That's our oxygen carrying protein. Vitamin B12 and folate. And those two help cells divide properly and mature. And then lastly, we need a steady signal from a hormone known as erythropoietin. Erythropoietin is made in the kidneys. That hormone travels over to the bone marrow and says, hey, we need more red blood cells. Go ahead and start the factory. And they put all those ingredients together, that iron, that B12, that folate, and they're making the red blood cells. Then they mature. Mature red blood cells are small, flexible, little biconcave discs that slide through our capillaries, kind of like tiny little frisbees. They're really bendy and they can get through nooks and crannies smoothly because of how flexible they are. They're packed with those ingredients from the bone marrow factory. We got our hemoglobin, which can pick up our oxygen, and they live about 120 days before they have just they've been Ubering long enough. They're kind of breaking down, and they're ready to be retired. They go over to the spleen to get retired, and we can reuse some of those materials, and then the rest we get out of the body. As long as our production in the bone marrow matches destruction in the spleen, then we don't lose any of that oxygen carrying capacity. We stay in balance. Life is good. But anemia happens when that balance gets disrupted. And there's a few different buckets of how we can cause those problems, okay? We can have a decrease in production where that bone marrow factory is really struggling. because it's missing key ingredients or the machinery is damaged and it can't produce those red blood cells like we want. That's what we're going to see when we have our deficiency anemias: iron deficiency, B12 deficiency, or folate deficiency. When we are deficient in those ingredients that we need, we can't produce those red blood cells, we become anemic. Now, another bucket, we can have, not enough produced, but we can also have increased destruction. We are destroying too many of our red blood cells, and we're not making enough to replace them. So these are things like hemolytic anemia, sickle cell anemia, autoimmune hemolysis, things that eat up those red blood cells too fast. They're destroyed and not replaced. Third and final bucket, maybe our balance is fine. We're producing enough, we're not destroying too much, but all of a sudden we start to bleed. Either we have acute trauma or a GI bleed, or maybe chronic bleeds where we have like heavy periods where we're losing too much blood every single month, for example, and we are literally just losing entire red blood cells. It's not the same as our second bucket where we were destroying the red blood cells. This is when the red blood cells are just like literally exiting the body, like with trauma, hemorrhage, and obviously we can't produce enough to compensate for that. So those are our three buckets. We're not producing enough, we're destroying too much, or we are bleeding out, we are losing our blood cells. Three big ways you can become anemic. So, what I'm going to do is I'm going to give you a few different clients, talk about how they present, and we'll think about which type of anemia makes the most sense for those signs and symptoms. There are some very specific buzzwords I want to make sure we hone in on in case they come up on your exams. So, first client here, we've got a 34-year-old woman who has been admitted for fatigue. Now, she works a full-time job, she's got two kids, and at first it makes sense. Hey, she's exhausted. But clinically, let's take a look at her, and we see she is really pale. Not just her skin, but I also want you to look at her mucous membranes and her nail beds. So look in those eyes at the conjunctiva. Her nail bed's almost white. And when she says she's fatigued, that can also present as intolerance to activity. So if she stands up to walk to the bathroom, oh my gosh, she's so lightheaded, she has to sit back down. That is beyond just normal fatigue. So she tells you in her history that she has really heavy periods. She tells you she is soaking through pads every hour on the first couple days. And recently, she's been constantly wanting to chew on ice. Okay, these are a few things that should put the puzzle pieces together for you. Really heavy periods, that's blood loss. That's one of our anemia buckets. We're losing those RBCs, we can't replace them. Constantly wanting to chew on ice is a symptom called pica. That is classic for our iron deficiency anemia. We've got chronic blood loss from these heavy menstrual periods. She's losing iron faster than she's taking it in. The body's still trying to produce, but it just doesn't have enough iron to make those good hemoglobin-rich cells. So her red cells are going to come out small and pale and not really be able to carry oxygen like we want. You hear pica, wanting to chew on ice. Think iron deficiency anemia. Now, what's our treatment for this type of anemia? We're deficient in iron, so let's give some iron. In the hospital, we can do an IV iron transfusion. Long term, we're going to go home on oral iron supplementation. And what I want you guys to remember about oral iron is that you don't want to take it with food, especially anything that has calcium in it, because that's going to impair absorption. But it actually really helps to take it with vitamin C. Vitamin C enhances our iron absorption, so I always tell my clients to take their iron pill with a glass of orange juice. So that's your first client. That's your classic iron deficiency anemia caused by heavy menstrual periods. Let's flip over to another client here and look at a different anemia presentation. Here we have a 72-year-old man admitted for anemia and confusion. He's also pale, he's got that pale conjunctiva, his nail beds, etc. But there's something else. He's moving slowly, his gait is a little wide and unsteady. His hands are clumsy and shaky. He tells you he feels pins and needles in his feet and his hands, and it feels like he's walking on cotton, like something just doesn't feel right. If someone tells you that, assess their tongue. His tongue is smooth, beefy red, and almost glossy. A beefy red tongue should send off an alarm bell in your head. This is B12 deficiency anemia. B12 is a vitamin that is really crucial for DNA synthesis in rapidly dividing cells, like those in the bone marrow that we're talking about, and also for maintaining myelin in the nervous system. So when we don't have enough B12, then our red cells, those precursors, they get a little weird. They get actually really, really big. Neurons can lose their insulation, that myelin. So the enlarged red blood cells, due to the lack of B12, is what's causing that tongue to be beefy red and causing those neuro symptoms. So you see neuro symptoms, beefy red tongue. I want you thinking, this person does not have enough B12. Now, this can be a dietary insufficiency, like they're just literally not taking in enough B12. And in that case, we're going to need to replace B12. It also can be due to what we call pernicious anemia, where we have a loss of intrinsic factor in the gut and we just literally can't absorb B12. So they're eating enough of it. It's the absorption that is the problem. And if that's the case, if we've got that pernicious anemia, then yes, we still want B12 replacement, but it needs to be done IV or parentally since they're not absorbing it in their gut. All right, so two clients, two very different presentations. We've got iron deficiency from chronic heavy menstrual periods. We have got pernicious anemia from a lack of intrinsic factor, not being able to absorb B12. Both ingredients to make red blood cells that have led to a decreased production. Let's look at one more client that's not making enough red blood cells. Here we have a client in her 20s admitted for severe anemia and potassiae. Now, she's coming from the oncology unit and was recently started on chemotherapy. Her CBC is looking rough. Low H&H, low platelets, low white counts. She's got pancytopenia, low cell counts everywhere. You see bruises on her legs, potassium on her arms, a low-grade fever. This is a sick client. Now, this is the classic picture of bone marrow suppression, or maybe aplastic anemia. It's not that we're missing an ingredient, we're missing the iron or the B12, but the factory itself is damaged. So it's not cranking out those red cells. It's also not cranking out white cells or platelets, but that's a story for another day. So with aplastic anemia, we're turning down the production of all of our cells. And that's why you're going to see both the anemia, fatigue, pallor with things like potassiae due to the low platelet counts. And usually this is an oncology client. So again, three very different presentations, and we could talk for longer, but I know you're probably approaching your limit of how much you want to hear me jab on about anemia. So let's use this opportunity to come back to our practice question, look at these different presentations, and tell me which assessment finding is most consistent with vitamin B12 deficiency anemia. We had the fatigue, pallor, brittle spoon-shaped nails, and craving ice. Is that B12? What do you think? No, that is classic for our iron deficiency anemia. The pica, we're thinking not enough iron. Maybe this client is bleeding, heavy menses, maybe they're not taking in enough iron. Pica, we're thinking iron deficiency. Okay. B, we had jaundice, tea-colored urine, and flank pain. Jaundice, tea-colored urine, and flank pain. We didn't actually go through this scenario, but if I'm seeing elevated bilirubin turning into a yellowing of the skin, byproducts in the urine with really, really dark urine, that's telling me we're actually breaking down too many red blood cells. That's bucket B, where production's fine, but we are destroying those cells left and right. We call that hemolytic anemia. The blood cells are being broken down rapidly. That's releasing the byproducts of bilirubin and hemoglobin into the blood and causing that dark urine. So if I see jaundice and tea-colored urine, I'm actually not worried about the production. I'm worried about the destruction. B would be consistent with hemolytic anemia. Now, for C, we had numbness and tingling in the hands and that smooth, beefy red tongue. Is that consistent with our B12 anemia? Yes, those are the big two red flags I think about with B12. The beefy red tongue that's coming from those large macrocytic red blood cells, and the numbness and tingling or neuropathy coming from the lack of B12, not supporting our myelin, that insulation around the nerves. You hear those two things, you're thinking lack of B12. C is correct. Our last scenario here, D, was sudden hypotension and tachycardia after a large upper GI bleed, which is our third bucket of that rapid acute blood loss. We lose that volume, heart rate goes up to compensate, and we have got to replace that volume loss. All right. That was a lot. There's a lot of different ways we can become anemic. My key takeaway for you is that it's really not a one size fits all. And I want you to be aware of those key signs and symptoms in your client that can point one way or the other. Don't forget those three buckets. We can have a decrease in production because the factory is missing ingredients, iron deficiency, B12 deficiency, etc. We can have an increase in destruction, like with hemolytic anemia, or we can have that massive loss with a trauma, a GI bleed, etc. In all of them, we don't have enough red blood cells, which means oxygen delivery to the tissues is impaired. At the end of the day, that's what anemia is all about. Right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.